Thank you very much. In the last meeting in San Diego, Ravi Mehta asked me to present what is your new idea about critical care nephrology. And I came up with something that I've been intrigued for a long time, and we're now trying to explore whether there is a feasibility for this project to utilize membranes not just as filtration tools, but rather as bioreactors or interactive compounds in the extracorporeal circuit. So in AKI, for example, there is an imbalance between pro and antioxidant factors leading to potential tissue damage. In CRRT, blood membrane interaction may lead to production of reactive oxygen species contributing to damage. So we have the syndrome, and we have also the contact with the potential external biomaterial. I believe that taking advantage of new membrane manufacturing process and membrane surface modification, we can perform a kind of antioxidant continuous renal replacement therapy. How? Well, first of all, let's focus on the fact that oxidant stress occurs when formation of reactive oxygen species exceed the body's ability to metabolize them. Oxidant stress is a common pathway involved in cellular dysfunction, tissue injury, and organ failure. And high levels of oxygen radicals inactivate mitochondrial enzymes, cause DNA damage, induce base hydroxylation and strand breaks, leading to cell injury and apoptosis. Injury caused by oxidant stress occurs in many clinical scenarios, including AKI, but also sepsis. And kidney is rich in mitochondria and therefore is highly vulnerable to damage caused by oxidant species. Ischemic perfusion injury and sepsis are typical conditions leading to AKI, where oxidant stress represents a key pathogenetic mechanism. And as you can see here, the production of reactive oxygen species due to different inflammatory processes may lead to intracellular calcium to rise and to activate the possibility of phospholipase A2-mediated damage into the cell. Now, it is well known that in critically ill patients with AKI, the level of advanced oxidative protein products is significantly higher compared to patients with non-AKI. So there is no question that having everything similar, this impact of oxidation, oxidant stress may be quite important. Again, this seems to correlate with the severity of AKI syndrome. So in a prospective cohort study in adult ICU patients, the level of AOPP was significantly higher in patients who developed stage 3 or failure in the Rifle-Akin classification. To understand this, we have to clarify that AKI is not an isolated event, and especially in case of sepsis, but also in general, we might have altered kind of inflammatory profile given by different levels of cytokines and chemokines. There might be the possibility for leukocyte extravasation. The oxidant stress operates in conjunction with this factor and together with also dysregulation of the sodium and water transport in the membrane. All these things may lead to distant organ injury, what we have called a couple of days ago organ crosstalk, with potential for damage in other organs. So the contact of blood with artificial membrane during CRRT also may result in elevated production of reactive oxygen species and AOPP by leukocyte. At the same time, AKI patients lack several defense mechanisms. So we are in a condition in which it seems that membranes may actually amplify this kind of phenomenon. So in addition to give antioxidant to a patient, which has been proposed, the idea could be to use membranes that actually block the generation of oxidant species exactly where they are generated. And in this case, for example, membranes in which vitamin E has been covalently bound to the surface of the membrane, and the membrane has been functionalized with this type of thing. Now, functionalization of membrane, there is an entire encyclopedic information, and you have to study industrial chemistry to understand that membranes are functionalized for different purposes. And I spent some time understanding and studying this thing, but what I have seen that this may be just the beginning of a new era in which, in this case, for example, from Japan, there is this process of linking alpha tocopherol to the surface of the membrane, which is made more hydrophilic, and the binding leads to a certain amount of alpha tocopherol on the surface and antioxidant efficiency. So somehow the way this works is the control of protein oxidation, the reduction of LDL oxidation, and the reduced erythrocyte damage. How? Basically by increasing the bioreactivity of vitamin E, which is linked to the place exactly where oxidant species are generated. What are the advantages? Well, the idea that direct scavenging of the membrane surface is preferable include the gastrointestinal absorption of oral supplement can be affected by many factors. Patient may not be compliant with treatment, or oral supplementation can be cleared by the dialysis process. So the idea is to generate to blockade the process exactly in the point where it is generated. The idea is to create a kind of in situ action, and therefore the result may be a kind of an improved biocompatibility, which may also affect other things, including activation of leukocytes, production of inflammatory cytokines, and other processes. In CRT, in patient with acute kidney injury, we did an exploratory trial, and what we found was a significant reduction in the production of oxidant species over time. This is T0, T2, and this is 24 hours. This is quite an interesting result that we have found, because the idea could be that as specific drugs are actually delivered to specific patients, for example, in oncology, we might identify specific patients that may benefit from specific membranes. So the whole concept is that we may enter an evolution in the, let's say, concept of membranes. We started with the first membranes. Very low biocompatibility. Cuprofen membrane had a lot of problems in terms of leukocyte reaction and so on. And we tried to improve this, and this was improved by treating the surface, making it more hydrophilic, and improving also the content of the polymer that was synthetically driven and less bioincompatible. Then, after that, we didn't understand clearly whether the better results were because biocompatible membranes were high flux and bioincompatible membranes were low flux. So the problem was that the development of high and low flux membrane with high biocompatibility allowed us to understand the importance of porosity and flux. And this added a new dimension to the capacity of the membrane. And today, bioproperty may actually represent a fourth dimension. Practically, in this axis, we may represent the biological capability of a membrane to interact with blood and with the patient. So in conclusion, what I presented to you is just a concept. We have shown in an exploratory trial that patients on AKI treated with continuous renal replacement therapy and membrane with vitamin E bonded to surface display a lower pro-inflammatory, lower antioxidant, lower oxidant stress profile. I think that this strategy may be important in AKI, sepsis, and CRRT, and this may represent a possible interesting application for the future. With this, I thank you very much, and we can move forward. Thank you.